We now have a wonderful presentation coming up by Dr. Sheehan Fisher. Dr. Fisher is the Associate Professor and Perinatal Clinical Psychologist at Northwestern University, Feinberg School of Medicine, and Associate Dean for Diversity and Inclusion at the Graduate School. His research career focuses on effects of perinatal and subsequent parental mental health on infant-child health outcomes, with a specialization in the emerging field of father's mental health. His aim is to conceptualize parental mental health research, to integrally involve fathers, to differentiate parents' impact on child and medical and mental health. His research dovetails with his perinatal clinical practice, including being the clinical director of the Father's Mental Health Specialty Clinic. He's also the chair of the International Marseille Society's Fathers Special Interest Group. Ultimately, the goal of his research plan is to optimize the health and effectiveness of the parental team, to positively influence the child health trajectory, starting during pregnancy. Dr. Fisher will be presenting on the importance of fathers' mental health in perinatal families. Please join me in welcoming Dr. Fisher.
Welcome, everyone. Thanks for attending this talk focusing on fathers' mental health during the perinatal period. I'm excited to talk about just some of the general ideas about fathers and how they experience their mental health during this transition within their life, and also how that impacts the family health. So first off, I wanted to just highlight that we all have had experiences watching TV and thinking about different views of fathers. There's been many different depictions of what a father is throughout history, and understanding that sometimes it reflects kind of even the era of that time. And even when we think about our own fathers, we have an understanding about what that meant to be a father, and also how that may or may not match how you understand the goals of fatherhood and how they should be involved as parents within a child's life. And this is becoming even a more popular topic even within media, thinking about what is fatherhood? Like, what does it mean to be a father in this day and age, and even how that is transitioning, including even ideas about masculinity, how the old views of masculinity may not match how we understand how to become a father now, or what is needed to become a father. So this is something that's becoming a hot topic, but we have a ways to go to really understand what this means within the family environment, and even what direction we're trying to take. So just in general, I want to give a roadmap of this presentation. We're going to talk about father mental health and the impact on the family health. We're going to talk about fathers from prenatal all the way through the postpartum period, and also about how can we engage fathers within a clinical setting to make sure that we're able to utilize them in a productive way to support family health, and also specifically about fathers as assets to support moms' mental health. So historically, this is how we understood the family unit. When we looked at the perinatal period, historically, many times we were thinking about how the mother's mental health and well-being impacted the child. And we are trying to move away from this direction to think more integrally about the father, and about how the father is a part of this picture. And for one, we need to think about the relationship between the mom and dad, and how they impact one another, like the interparental relationship, and sometimes the co-parenting if they're not in a romantic relationship, and how that also impacts the child's well-being. And then also how each parent, the mom, impacts the child for her mental health, which is the majority of the perinatal literature. But now thinking about also the father's mental health. How does the father's mental health impact the child development? Now, even though I designed it this way, you can even think about these as bidirectional arrows, that the child also has an impact on the mom's mental health or the father's, and also even the interparental relationship and the parenting behavior. So it really is a family system that we're talking about, the dynamic between all the different players within the family dynamic, and how that actually leads to understanding family health in general. And we need to also emphasize that fatherhood starts during the prenatal period. Like historically, we think about fathers starting maybe in the postpartum period, or even a little bit beyond then, where, okay, where's the father's role? But we need to think about this, that the father is responsible and needs to be engaged throughout the whole process from conception all the way through the child's life to ensure that the father's engagement has an impact on the well-being of the family. So first we'll talk about paternal mental health and how that contributes to family health. Well, for one, we have the social environmental context of being a parent. Nowadays, many times both parents are working, but also trying to juggle their personal life and their family life. And it's a lot that they're going through to try to manage it without really a good guidance on how to have that balance. So when we think about the transition to parenthood, the father's going through, similar to the mom, many different aspects of change. For one, they're trying to, as I mentioned, balance their work, family, personal life. But we know that many times fathers have less access to parental leave. For one, even in our country, in the US, in general, parents don't have great access to parental leave, and we don't have federal approved that everyone has access to that leave. But even when individuals have access, usually it's about maybe 3 months for the mom, and for the dad, it's about 2 weeks. So fathers don't have as much access to this parental leave that has been shown to impact their mental health and their well-being and their family health. And even if they do have access to it at their job, also is not always encouraged or even a little bit frowned upon about why are you taking leave? Like there's still some of those gendered sexist views about who should be taking leave to take care of the child. Like, what are you going to be doing while you're on leave if the mom is also there? Fathers feel the pressure of the financial responsibilities that it takes a lot to afford, especially even in our country, once again, of childcare or schools and all these other things, that pressure starts to get heavier on parents as they're going into this transition. And therefore fathers, based on our once again, a gendered view of the way the world society works around the pressure, or the father feeling like, well, he has to make sure his family's okay. The interparental relationship starts to change, where you are less focused on one another in the way that you were prior to the child coming. And many people struggle to find that balance of ensuring that their relationship stays strong, even during becoming a parent, in addition to even changes in the sex life. Not only those first 6 weeks postpartum, but even beyond then, many times individuals' sex life starts to change in ways that isn't healthy for their relationship. Fathers many times are viewed as a secondary parent, to the point that even the term mother-father has become almost like a pseudonym for primary or secondary parent. And in that role, many times fathers are struggling with, okay, well, where's my place within the home and with raising a child, and how much are my views on parenting and engaging with the child viewed as a part of the conversation versus viewed as something that's secondary. We're learning that fathers even go through hormonal changes that we didn't historically look at fathers to look at their hormone changes because they're not carrying the baby. But the fact is that we are seeing that testosterone does change during this time, and that's been associated with mood changes. So we need to understand that better about the biological changes that fathers go through during this experience. I've added this to this slide about environmental factors because COVID happened, and that really was another thing that really impacted parenting. Some of it good and bad, where many times, especially during the lockdowns, fathers and moms were both in the home with the child, which gave more access to the father to be engaged in the parenting activities and to be able to support the mom in her experience. But that, of course, has gotten changed. But many times, many jobs are still offering virtual options for working, which is allowing there to be more involvement. But there's also other things like recession that creates financial stress. So environmental factors can also affect the parenting experience. And then even unexpected perinatal events, like having perinatal loss or a NICU, like if the mother's mental health is declined, or even her physical health, or even death, these things can also affect the father. And it's in general, the father's previous mental health, like their mental health prior to the mom becoming pregnant and or the prenatal period, can also predict how their mental health will exist during the postpartum period. So when thinking specifically of perinatal depression and family mental health, we know that approximately 10% of fathers will have depression during the perinatal period, which is about half of the rate for moms, but this rate is the same when you look at men and women in general, that this is about a 50% odds that they will have depression. but this rate is still higher for fathers during the perinatal period than any other part of their life as a male. The measures of depression that are commonly used, the EPDS, that's designed and been validated for utilizing for fathers, but also within like a hospital setting and other settings like the PHQ-9 or the Beck Depression Inventory or the IDS are also commonly used measures of general depression. From that, even though postpartum depression has come like the hot topic and the terminology is commonly used, we also understand that parents are at risk for developing anxiety. And there's measures like the GAD-7 or the Beck Anxiety Inventory that can be utilized to assess anxiety symptoms or screen for them. And the same for bipolar disorder, that the MDQ can be utilized, which is getting a lifetime of that they likely have a bipolar disorder, or the internal state scale that if they already have the diagnosis, helps them to assess changes over time of their mood state. We don't talk about bipolar disorder as much, unfortunately, but it is a real risk factor where there's elevated risk of having either repeat or new onset of a hypomanic or manic episode during the perinatal period. Think about like the fact that you're not sleeping as well and the different stressors makes people more vulnerable, or the person maybe never had a history of a diagnosis, but with those changes can have like a new onset first time of it getting to that level where they start to have hypomanic or manic symptoms. So these are the things to consider about fathers' mood and mental health during the perinatal period. And we know that fathers are at increased risk of depression during those first 5 years of fatherhood, that being involved with the child, which is a positive thing, also comes with some of that stress. So therefore, that first 5 years is a vulnerable period, even though there's a peak of risk of depression during the around 6 to 9 months postpartum. I did a study a while back looking at fathers and mothers' depression, and what we used was the EPDS, but what I did was try to find a way to have a report of the father depression when the father was not at the maternal child healthcare visit, because especially historically, fathers were not as much engaged in those obstetric visits, and it would be beneficial to still get a rating of their mood, even if they're not in the room. So what I designed was an adapted version of the EPDS that could be the mother's rating of the father's depression. And we found that it was reliable and valid measure of father depression. But as we're going through the item levels, what we noticed was that fathers experienced depression a little bit differently, where they were less likely to endorse the emotional symptoms of depression, but were more likely to report on things that were about like neurovegetative or other aspects of their mood. So this pointed to some other literature looking at how men manifest their depression. We know that men typically tend to underreport their symptoms, and even there's a clinician bias about diagnosing depression, not less likely to diagnose it in men, but also to highlight that there is the masculine cultural interpretation of the experience. We know this in other groups where for different racial ethnic groups that depression can be manifested and experienced differently. And we're starting to understand that similarly within men, because of the masculine culture, men are less likely to report and or even experience sadness in the way that we traditionally view it. They might start to experience in other ways how they might articulate it that might be missed by traditional measures. So there's a concept called masculine depression, in which we notice that men are more likely to engage in externalizing symptoms like acting out or misbehavior, and be more likely to endorse less emotional internalizing symptoms of sadness. So I will show an example. For this is the masculine depression scale. And this measure looks at, you see here, the internalizing symptoms that are reworded in a way that is more receptive to men. So for example, they might less likely to say, I am depressed or sad, but they might say, I just can't win, or that I've been feeling numb, or others like no one's gives me a break. So like things that shows how they are in a depressive state, but not necessarily asking the question in the same form as a traditional measure. In addition, the masculine depression scale includes items for externalizing symptoms, like I don't get sad, I get mad, or I've been drinking a lot, or I've been needing more sex than usual to feel good. So when men are engaging or experiencing depression, they're more likely to engage in either aggressive behavior or they might even use substances to cope with it, like having an extra nightcap at the end of the night, or even becoming more sexual as a way to deal with their stress. So they externalize their symptoms. And so there's something at least to take into consideration when we are assessing father depression, about making sure that we have measures that would also cover their experience of this mood state. Another study that I did want to highlight was just looking at depression in mothers and fathers over a 2-phase study, starting during the postpartum period and then following up 3 years later. And what we found was that both mother and father postpartum depression was associated with future toddler mental health for internalizing behaviors and externalizing behaviors. And what I want to highlight from this model that I'm showing is that, and I'm not sure if you can see the arrow, mother depression postpartum predicted future depression, which is the mediator between the mother's postpartum depression and child internalizing and externalizing behaviors. So this mirrors what most studies have shown, that mother, when she's depressed postpartum, that is associated with future internalizing, externalizing behaviors in the child. But what we did is that after controlling for that, after accounting for the mother's depression, we assessed, did the father's mood actually matter? And what we found was that yes, even after accounting for mom's depression, father's depression predicted risk for child developing internalizing and externalizing behaviors. This matters because the idea is that if we were to develop treatments to support mom's mental health and make sure the mom is well, if we only focus on the mom, that child is still at risk. And this gets back to that picture I was showing about integrating the father into the pictures, that just treating the mom still makes it that the child is not in a healthy environment and could be at risk for developing mental health issues long-term for them. And therefore, we need to make sure we're addressing both parents when assessing and also intervening on perinatal mental health. Next, we think about father involvement, and that postpartum is too late. We need to start father involvement early. We know that father's intention of having a child and father involvement during the prenatal period actually improves mother's prenatal care. In addition, when the mother is dealing with substance use, the father involvement is linked to reduce smoking and alcohol use. But if the father is engaging in their own substance use, then it is more likely that the mother will also continue to do so. We know that the absence of a father across race and ethnicity is related to low birth weight, preterm and very preterm birth, being small for gestational age, and even infant mortality. So therefore, having a father engaged and involved is important for these health outcomes, or birth outcomes. In addition, we know that father prenatal involvement predicts postpartum involvement, and that's the thing that I always highlight. The father getting engaged during pregnancy, and that level of realizing that they are responsible for this child, that gives that buy-in and gets them practicing engagement, predicts how much they're going to be engaged long-term. So if we're going to start trying to get fathers engaged postpartum, we are already too late. We need them to be engaged even during the pregnancy, and not just building the crib, but holistically engaged in that experience. Actually, it will lead to them being more involved fathers long-term. In addition, we know that father support during pregnancy predicts less postpartum anxiety and depression in the mom and infant distress. And then even father prenatal depression is associated with the mother's prenatal and postnatal depression. So all these factors are essential and they just scratch the surface for why fathers need to be engaged during the prenatal period to support the well-being of the family long-term. At birth, fathers need to be there too. That having the support of a companion like a father reduces the rate of C-section, of needing an epidural, or even the duration of the labor. And also fathers present at birth, once again, helps them to transition to parenthood, that they are seeing that they are part of this experience, that they are getting more of that buy-in to know their role. And it also helps them to feel more attached to the infant, and even improves the relationship with the infant and the mother. So this is an important part of their experience of being there at the birth, to psychologically adjust to this new role in their life and to be attached and engaged with both the mom and the child. when it comes to once the baby is born, father engagement around parenting is important. From, this is just, a brief overview of when the baby is an infant, the vocalizations, the eye gaze, the facial expressions, the physical contact, all those ways that the father engages with the child is important for the child's well-being, in addition to their development for like feeding and providing safety, mirror play, physical contact, and like kind of engaging with the child physically, and even helping them to explore and be more independent. All these things are essential for the child's development. As the child gets older, there's more focus on like boundaries, exploration for the child to become more and more independent, teaching, thinking about age-appropriate play and how that helps the child's mental and cognitive development. And I also emphasize rough and tumble play, which fathers are known to be more inclined to engage in, which is very beneficial for the child's development. The child learning that you can have rough housing and feel uncomfortable, but that's okay and safe, is how they also then learn that when they feel stressed or feel a little anxious, that feeling is not a bad thing, that they can conquer it and be able to manage their own experience within it. And rough and tumble play has been shown to be essential toward that part of the child's development. But of course, there are barriers to father engagement. There's their own mental health in whether dealing with depression, anxiety, or other types of disorders. How much autonomy they have toward that change of their engagement. Like, are they able to make their own choices on how their style of engaging with the child? Their own personal culture, and culture is a broad term, because that could be masculine culture, that could be being in the US, that could be their own racial ethnic background, and how that plays into how they understand their role as a parent. Time and access, just like I mentioned earlier about having parental leave is a factor, or just making sure that they carve out time for, knowing how to balance that work environment versus making time for the child. These are things that can limit their ability to be engaged in parenting, but needs to be addressed. And even their own belief about their competence. Like, one thing that I always highlight is that if someone doesn't feel competent in something, they tend to disengage from it. And it doesn't give them an excuse to do so, but it is something that we have to take into account, that fathers need to develop more experience and have more competence around engaging with children, because the more they feel competent in it, they're more likely to do it. And also just to, of course, highlight personal will. You can't force them to do it. So therefore, they have to develop their own will and desire. And that's something that they are personally responsible for, to develop that will to be engaged with their child. There are different measures of father involvement that can be useful. Historically, there were only like single item or mother report, or just a duplication of what's already been done for moms. So we want to be conscious about ensuring that we have other measures. So there's some measures out there, like the parenting self-efficacy scale, the inventory of father involvement. These are things that are useful for assessing father engagement within a clinical or research setting. But Dr. Garfield and I also developed a father involvement in health for preschool-age children, thinking about how different types of involvement, thinking about it not only about accessibility, engagement, and responsibility, these being separate buckets of involvement. And then from there, thinking about almost like within a matrix of how these things relate across acute illness, the child's general well-being, the child's emotional health, and role modeling. So really thinking about broadly, what is a full comprehensive view of father involvement in health during this time? And we made sure that it was designed to be and was validated for residential and non-residential fathers, which is also important, that just because a father's not in the home doesn't mean he's not involved. We have that kind of myth that is spread, but the fact is that fathers can be very involved in their child's life, and sometimes even more involved than even residential fathers. And living arrangements doesn't necessarily dictate whether the father's engaged. So to highlight, we do want to make sure that we are incorporating more about the father's mental health and their experience in the family unit, so that we, one, equalize the load of the family responsibilities, but also understanding the impact of both of the parents on the child. So how do we get fathers engaged? How do we get them involved within the clinical practice? And I listed out across different parts of the perinatal period, how do we get them engaged in this work? Well, within the healthcare system, we need to be conscious about our marketing materials. What materials are we utilizing to market, and do they include pictures of fathers and other individuals as broadly birthing and non-birthing parents? Are we making sure that those materials are inclusive? Even the name of the clinic, if it's like the maternal child healthcare system, that name alone says that there is no place for the child or for the father. And we have to be conscious about that, because we don't want to be supporting that this burden only falls on the mom to take care of this child and that her health is only the thing that's a factor. We need to make sure that both parents see their responsibility and make an environment that's conducive to them getting the support that they need. When the father comes to the visit, whether it's like OB-GYN visit or the pediatric visit, are we giving eye contact? Are we actually engaging with them, having some level of conversation, even if they're not the focus, making sure that they do feel included, because they do have an impact on that environment. We need to be conscious about our own gendered bias beliefs. And that is not only about ours, but across the whole spectrum of the healthcare system, from the front desk, the staff, technicians, nurses, doctors, everyone needs to be aware of it, because I've been in so many situations personally and in my professional environment where people just make these comments that, you know, they keep instilling these gender biases that either dismiss the father's role or discourages engagement, or doesn't necessarily take into account even the family's decision about how they want to split up their responsibilities. And that even goes along with the policies. Many hospitals have it, that policy that the father is not the emergency contact, for example, that is automatically put as the mom, and rather than asking the family, who do you want to be responsible for the child's health and well-being, so that when something comes up, we reach out to who. It's already a gendered view of it that doesn't allow the family to decide and get away from some of the gendered norms. And even in screening, we do need to make sure that we're using gender appropriate measures of screening, but also, like in Illinois, for example, we have postpartum screening for all moms, but we don't do that for fathers. And that's something to consider down the road, is how do we make sure that screening is inclusive? The other part is about getting the foot in the door, like having the father come to the mother's clinical visit. So, like, for example, if I'm working with a mom, usually I ask for the father, with her permission, to come to at least one of the visits. And if he does, it helps him to understand, like, oh, this is not the end of the world. It's not that scary as I thought it would be. And for him to start thinking about his own mental health and maybe getting support individually outside of working with me. So, like, it's important to help to get the foot in the door, so they realize mental health is not the scary thing to address. And you want to help fathers to be more aware of their own internal experiences rather than solely focus outward. Like, they need to not just think about, okay, what do I need to do to take care of the kids, to make sure that my partner's okay, to make sure I keep my job, but what am I going through inside, and being more aware of it. Giving them psychoeducation about the impact of the paternal mental health on the family, that sometimes the buy-in is literally, they won't do it for themselves, but they know that it's going to impact their baby. Then they're like, okay, fine, I will then take serious my mental health, or I will go get support, because they realize that it actually impacts the people that they love, or even their partner. Even trying to address their own biases. They might have biases against the psychiatric treatment from their cultural background, personal views, views around from masculinity, but helping to address those will be important. And even giving them a range of options, making sure they understand that, hey, you don't have to necessarily take medication, or you might be able to do behavioral therapy if you're not comfortable with more of a dynamic approach, like really helping them understand there are options of what they can do as a starting point, rather than feeling like they have to buy into the whole thing. They can just start somewhere to address their mental health. And then even in clinical treatment, we need to make sure we're using not only gender-specific measures, but also making sure that the types of treatment to address the father's concerns. For example, when thinking about medication, antidepressants, sexual functioning usually is very much on their mind about, if I take this medication, will it impact my sexual functioning? So these are things that we need to make sure we are addressing based on their specific needs. And even thinking about father-specific stressors that might impact their mood, and making sure that we don't just think about it from the general perinatal world of how it historically was viewed of what would impact parent mental health, thinking about that from even their specific gender and how that might be relevant to their mood. And even a lot of times when I'm working with dads, we do have to work on redefining strength and masculinity, and even success. What does it mean to be successful? The old school view of success was maybe working 60, 70 hours, never seeing your kids, and that was success. But many times fathers are thinking about, well, I don't necessarily want that promotion, or I want to negotiate certain things because I don't want to give up my time with my child. And that is a version of success, even if it may not mirror their predecessors. And doing what you can to help a father to develop confidence and agency and confidence as a parent. That might be like learning things and taking classes. That might be, getting opportunities to practice, but like for them to not think they get a free pass. Well, I don't know how to do it. That's it. Like, no, how can we engage them and help them to develop competence so they become a fully competent parent that could be an equal parent within the home? Next, I want to though also highlight a separate part is that we talked a lot about father mental health and about their experience, but even we still know like moms are at higher risk of depression and other disorders during the perinatal period. And one thing that I think that we're missing is the opportunity to utilize fathers during the perinatal period. Fathers can be an asset to support mom's mental health, but we want to think about this from a strength-based approach. But why? Within the perinatal world, I do research and clinical practice. We spend a lot of time in the federal funding, a lot of money to develop the best treatments to support mom mental health and how to assess and treat her. We then take that research and then we put into a clinical practice. We try to support the mom, give her the proper medications that addresses her needs and whether she's breastfeeding or not, and things to make sure she has the best medication and the best behavioral interventions to support her growth and well-being. But the mom is the one who has to go home and now and do that. What I'm saying is that we put all this pressure on the mom to have to fix her well-being, while also the mom many times has to work full-time and take care of the house and take care of the child. And we need to think about how do we not be part of that pile-on the mom for more things she now has to address, including now her mental health. We need to think about what ways can we utilize the father to support her mental health so that it's not only on her shoulders because there's already enough there. To do that, though, first we have to counter some of our pre-assumptions. We assume like our father's not interested or willing. We could discuss like fathers are moving in the direction of being more engaged and capable and also available to be supportive of the mom's mental health. We also have to think about our own biases around race and ethnicity. Like so often historically, we talk about, for example, Black fathers being unengaged fathers. We need more Black fathers in the home. But the recent research from the CDC and even since then has duplicated that Black fathers are the most engaged fathers across all the different groups. But Black fathers may not always live in the home. Just because they may not be living in the home doesn't mean they're engaged fathers. And those who are living in their home are actually way more engaged on the day-to-day caretaking and the actual direct engagement with the child. But the stigma still is what people assume to be true. So we have to be conscious about our biases in different ways about fathers in general, or even around their different demographic variables that we assume to be related to their level of engagement or willingness to support the mom or the family. And the research over the years has shown, as you see on the right-hand side, that fathers' work outside the home has been about the same since 1965 to now, but their level of housework has over doubled and their level of childcare has almost tripled. And we see that in comparison to the moms that, yes, moms are still the ones doing the lion's share of that work, but and also are starting to do more paid labor too. But we can see that there's a trend toward fathers getting more engaged in the home while still sustaining the same level of work outside of the home. But there's different ways that fathers can be a support to the family. First way is that the father can be an advocate. I use this picture because I did a talk a couple of times with this individual where he was advocating for his partner. She was dealing with severe depression and it was getting to the point that she was feeling suicidal and going through a lot of distress, but the doctors didn't always take her seriously. They said, well, I don't want to misquote, but I think that almost the phrase was, you're too pretty to be suicidal. Like basically an idea that was so dismissive. And this father was advocating for her, trying to fight to support her, trying to make sure that the doctors knew that she was suffering and that he was concerned about her well-being. And yet the doctors did not do everything they could to make sure she was okay. And it ended up that she took her life. So what I'm saying is that when fathers are advocating, we need to take them seriously, and we need to even empower them to advocate for their partners. Tell them, hey, go talk to your family or go talk to the other doctors. Make sure that you do know you have the right to advocate for her well-being, rather than that they're supposed to be the one that's quiet in the room. Fathers are also beneficial for assessment. The father is the one who lives with the mom on the day-to-day, so they can look, if we train them, they can be aware and look for signs of depression, signs of anxiety, and to know what that looks like and how that can evolve from the prenatal to postpartum period and beyond. Fathers can even be aware of what does bipolar disorder look like. Even if the mother never had it, I usually still provide that education, because sometimes moms have first onset of bipolar disorder. So you train the fathers about what this looks like. Yes, she seems a little happy, but is it excessive, or that irritability to that point? It's not that the father would diagnose the mom, but he might raise a red flag to say, hey, we need to follow up with your doctor because something seems to be out of kilter. And same thing when it comes to like OCD and even psychosis. The mother may not even have had a history of it, but at least the father can be aware what it looks like, so that if there is a new onset of these symptoms, then the father can intervene and try to support the mom to make sure she gets the services that she needs. That also applies to suicidality. Not just simply, okay, if she says I'm suicidal, but what are the other signs of suicidality that father needs to look out for? Like the mom starts to give away precious items or becomes hyper-focused about getting their will in place. What are the things that at least you can ask her, hey, I see this coming up. How are you feeling? What's going on? And then the father could be even a part of making sure the doctor knows about it, but also even a part of the prevention plan, that they can talk to one another and make sure that they are connected with the treatment team with her permission only, to make sure that they can provide support to make sure her safety and well-being is held as the primary concern. And even if the father needs to know, when can they feel confident to make a judgment call calling 911? Like when they're like, you know what, I can't reach the doctor, maybe it's like 2 a.m. in the morning, but I need to make that call to make sure that she is safe. Fathers can even be involved with the treatment. They can assist with the behavioral activation, making sure that there's a conducive environment for the mom to take care of herself. Okay, you know what? I'm going to take over all the responsibilities in the home, and you could take that hour to do self-care or to do your homework, or even reminding them for different parts of the homework. Once again, only with her permission to be that engaged, but he could be an asset to ensure that she is getting the environmental support or even the encouragement to engage in her treatment. And then even around psychoeducation for medication. So often the mom might take months to finally decide to take a medication because she's worried about the impact that might have on the fetus or the baby. And you might have to work hard with her to convince her about why this is beneficial for everyone's well-being. And then once she is convinced, she goes home and tells her partner, hey, I'm going to take this medication. But since he wasn't involved in the same informational aspects of psychoeducation and engaging with the doctor, then he doesn't feel comfortable with it. And then that might actually discourage her from taking the medication. So sometimes it's actually beneficial to make sure both of them are part of that conversation. Not that he would give permission for her to take it, but at least for him to understand why she's taking it, and to make sure that he can be supportive of her decision for her own well-being and for the child. And we need to get fathers, of course, involved in prenatal and postnatal involvement, like that they can be encouraged to support the mom by attending the obstetric visits prenatally, that they can adopt responsibility for that prenatal preparation, not only just making the crib, but like broadly, like calling pediatricians to figure out who they're going to work with, or other aspects of that planning. And even thinking about planning postpartum time. Fathers might have to talk in advance with their bosses about how can they make sure they have time off during the postpartum period, so they have time to be able to bond with the infant and be able to be an equal partner with the mom during that parental leave. And even assessing the mom's needs during pregnancy, that the father should not only assume what she might need and take initiative, but also even ask her what does she need to make sure she's feeling supported. Then during the postpartum period, fathers can learn about skin-to-skin contact. Like that's an important thing, like that for both parents to have that. Men cannot breastfeed, but they can assist with the breastfeeding to help make sure that she feels supported and reduce her stress. They can learn different competencies to make sure they can engage in all aspects of their parental responsibilities. and even some of the periphery responsibilities like, cleaning and cooking and other things to make sure that they are taking that on versus that falling on the mom's load, because we see that gender divide that typically relationships tend to be more egalitarian, but once the baby comes, then they fall into these traditional roles and not even the ones that they necessarily agreed to, that the mom fully signed up for. To be sure, there's different things to consider around like confidentiality, as I said, and boundaries. When it comes to fathers, making sure, yes, there's risk sometimes of domestic violence, so make sure that we do account for that, and that, sometimes the father's not engaged, and therefore we have to get them to see the value of engagement. But also, even though this talk was specifically about fathers, which we're usually talking about cisgendered fathers or men in that environment, we need to also think about other families and think about birthing and non-birthing parents broadly. And we're even thinking about other dynamics of non-traditional families where maybe it's about other family members being a part of that parental role or co-parenting role rather than being a father. So we need to think broadly when we're thinking about these things. So in general, our role is to support the whole family unit, to make sure that everyone in the family is supported, the mom and father and child, and making sure that we provide an environment that isn't biased based on gender norms or gender biases that even we might hold on to. I just want to at least highlight that recently we did I was the guest editor for a special issue thinking about fathers as assets, support mom mental health and family well-being. So this was published within the Archives of Women's Mental Health, a collection of research across the world, really highlighting how fathers can be important within the family health and mom's mental health. So future directions, we need inclusivity. We need to think about there's the perspective of the perinatal mental health research and clinical practice is based on a heteronormative view. We need to move beyond that. We need to make sure that we are thinking about non-birthing, birthing parents and different diverse family dynamics that can exist and make sure that we're supporting all of them versus for perinatal period to be such a heteronormative view is no longer appropriate or never is appropriate, but we need to move away from that view. Within research, we need to include fathers into perinatal mental health studies and think about fathers' contribution and their mental health and how that affects their environment, but also factors that affect their mental health, like their hormones and masculinity and other aspects of their environment that may not have been studied previously. And we need to understand how both parents' shared and unique experiences impact the family health. And then on a clinical setting, we need to find, like I have a father mental health clinic, but we need more of that, of clinics that are specifically focused on father mental health. We need to do screening for perinatal depression in fathers. We need to have interventions that are tailored to them specifically. Parenting classes that's becoming more popular that are focused on fathers to give them education to help them adjust to this new role. And as I said, even in the clinical setting, inclusivity around non-birthing parents broadly, because these experiences can be shared across many individuals who are non-birthing parents, but also they have their own unique experiences that we need to understand. And that might also include having more inclusive intake forms that are inclusive of the full breadth of the family unit and the way that can look. And then we need to change our culture, like the culture around masculinity. People talk about toxic masculinity. It has a long way to go to make sure that masculinity includes aspects of nurturing and being an evolved parent and having equity and equality within the home and getting away from some of those historical norms. We need to be sure that people are aware that postpartum depression can exist in both moms and dads, and that we need to increase the norms of the father responsibility in the home, that the father even the father being involved doesn't mean cherry picking what they want to do, but broadly getting engaged in all the aspects of what it means to be a full parent. And another way to do that, though, to change our culture is media. Media has such an impact, even more than our research, on how to make sure that we change the norms of the way we view parenting. And then policy, there's a lot of policies that need to be addressed, really just around federal policies to make sure there's inclusion, make sure the files are on the birth records, make sure we have parental leave for the families, even custody issues, like making sure that we are not creating biases, but really making a environment that is actually about equality within the home and equality across gender. So as a take-home message, fathers have an important role in the home. Fathers' mental health does matter and has an impact on them and also on the family. We as clinicians and practitioners must learn how to engage fathers. It is our responsibility to make sure we create an inviting environment, but also that we are providing the education to make sure they understand why we want them to be engaged. And that moms shouldn't have to go through the perinatal period alone, especially when they're dealing with mental health issues, that we need to think about how can we utilize the father or their partner, whoever that is, in a way that's conducive to the mom feeling supported in the home, not just during her clinical visits. So we need to think broadly about this. This hopefully is a conversation that helps you think about your own practice or research and think about how you can see the value of the father or non-birthing parent within the work that you do. There's different educational opportunities out there. I am the chair of the Father Special Interest Group of the International Marseille Society, and therefore we provide a lot of workshops, symposiums. We're actually doing another one in November that will be from fathers from all across the world, from Africa, Middle East, Asia, South America, and US, thinking about what does fatherhood look like during that time. And then also, Lisa Lappin-Carr is the chair of the Sexual Gender Minority Special Interest Group that's getting to broader thinking about what does it look like for non-birthing and birthing parents and how we can understand how to support them within our research and clinical practice. So feel free to reach out to us if you're interested in learning more or joining these groups. So I'll leave now time for questions, and I thank everyone for your engagement in this presentation.
Thank you, Dr. Fisher, for that very informative talk. We appreciate your time. We have some questions. We actually have a lot of questions that have come up in the chat box. We're going to try and address as many of them as possible. Our first question is, I'm curious about consideration of fathers' mental health in families with two fathers.
We think this is where we need more research. We don't always have, like when I'm actually doing a presentation in a couple weeks just focused on that, about non-birthing parents in general. And unfortunately, a lot of the perinatal research has been such a focus on heteronormative families that we don't have as much of an understanding of what the experience is like for when it's two fathers or other types of dynamics of non-birthing parents. And that is what we need, more of that type of research, but also more availability within clinical practice of those who are skilled at supporting these families.
Thank you. Our next question is about resources. What are some basic resources for fathers/partners who may be experiencing postpartum mental health symptoms? Would you comment on some safe spaces for them? So
well, there are some support groups through PSI. If you look at their website, they have a lot of options for resources and also support groups to be able to encourage fathers to have a space where they can engage with one another and also to get support around their mental health. But that's also part of what we need is more individuals who are trained in this area to be able to offer these services.
Great, thank you. So PSI support groups is a good resource for our audience. Next question, Dr. Fisher. What is the incidence of psychotic and bipolar disorders in partners and fathers in the postpartum period?
I don't have those numbers right in front of me. I know for the bipolar disorder that the risk of having a hypomanic or manic episode is increased during the perinatal period compared to other periods of a man's life. You can link that to just the changes in like stress levels and sleep deprivation that typically can lead to an episode, but I'm not sure about the data exactly for the numbers or the new onset of bipolar disorder.
And then, of course, psychotic disorders is definitely a place where much more is needed because we have limited data even on women.
Exactly.
Lots more needs to be done. Yes. What would you recommend? How would you recommend discussing partners/fathers' role as we prepare birth plans and postpartum plans for our moms patients? How would you recommend incorporating the role of a father in that process?
Well, a broad stroke, I have like a whole protocol specifically for that. Usually when I'm working with a mom, I bring in the partner for one session to kind of work through creating a postpartum plan. But a lot of it, as I partially mentioned, was about like assessing the mom's mental health, being supportive of it, but also about like for them to think about what do they want for their family so they can get away from the gender norms versus how they want to design things and what are maybe some deficits that exist now and how they can work on that during the prenatal period to be ready for the postpartum period to make sure that the split of responsibilities is equitable.
I like that, equitable split of responsibilities, or maybe a little lopsided with the dad taking some more. All right. How can we engage partner and fathers in supporting sleep schedules for co-parenting a new baby? I didn't make these up. These are coming from the audience.
This comes up quite often, and I talk a lot about it, especially depending on the mental health of both parents. Like, for example, I've had cases where one person's bipolar disorder or not, and kind of think about those sleep schedules versus if it's depression, really making sure that they understand that it is both of their responsibilities to divide that load, but it also depends on who's working and like the schedules around that, and that changes throughout the first year postpartum many times. So many times we have like staggered and multiple plans that address the needs of each person at different times. But this is kind of the focus is to make sure that they understand it's both their responsibility to be responsible for the child during the night and not just falling on one person's shoulders.
I like the idea of being flexible about it and, you know, shifting responsibilities and tasks as the perinatal period progresses, because the baby's needs might change too. Perfect. Can you okay, this is a great one. Can you comment on the impact of adequate paternal leave? In the US, the average is about 6 weeks. Do you recommend on a better number, or do you have data from other countries?
Yeah, I don't know if it's even 6 weeks. At least a lot of my dads are like, they get 2 weeks, maybe sometimes they get more because it is depending on the company of what they offer and of course even what state you're in. You know, a lot of other countries have much longer leave where they can either split it between the mom and dad and they choose, or that both are allowed to have like a significant amount of time, like 6 months or even a year at certain places. We do need to make it federally available so that, you know, companies aren't just choosing, and also making sure that if it's available, that is not frowned upon, because that's the other part is, since it's not like federally supported, many times, even if it's available, people still look at the father a little bit weird, or why are you taking that leave? So we do need to make sure that the father has time to bond with the child, engage, and not already basically upfront creating this gender divide where the mom is home with the kid maybe 3 months, but the dad goes right back to work, which then automatically puts it in a position that they're conditioned to believe it's the mom's responsibility to take care of the kid. It is definitely a cultural shift and a political shift that we have to move from.
Yes, so much more advocacy and so much more needs to be done. Next question, what ways can we support a father if a father is absent or in part absent, like deployment, incarceration, unhoused in a different location to the mother and baby, or other such scenarios?
Yes, like for situations where they're not choosing to be absent, I think it is important for them to consider kind of what can they do, what could be their role, rather than disengage. Especially, you know, that's a heartbreaking thing to be far away from your child and not have access. So therefore, you have to figure out, they have to find ways to bond and engage, and also think about how can they still support the mom even from far away. So it is something that does come up, unfortunately, more frequently than we would prefer, but it's something to think about even psychologically. How can they still keep a connection with this child, even if they're going to be separated for a period of time?
Yes, definitely. I had a question about father-infant attachment, and I was wondering if you could comment on that. That's something we work hard here at El Camino to implement in our MOMS program and on our inpatient perinatal unit. But just your thoughts on father-infant attachment and how that work can be implemented in settings like ours, or generally speaking too, any other settings too.
Well, first, I think psychoeducation is needed for the father to realize that bonding is actually helpful for the child's development and health, and also for them to get more attached and engaged in their child's life, just having that time to bond. And then psychoeducation is not only about the importance of it, but even how to do it. Sometimes fathers, especially, you know, when they think about their own fathers, they weren't necessarily touchy-feely or engaged physically. So parts of it, just even like the skin-to-skin contact or the holding, bathing, different things that they might shy away from, is something to help them to understand this is important and give them guidance that this is a part of masculinity, to be involved with the child and to have a close connection that can create that deeper attachment. Another thing is for them to be a part of the breastfeeding experience, so they're not fully disengaged from it, but they can help with that, or even like you said, at nighttime, like part of that soothing. Like they need to get away from the idea that just because the baby keeps crying after 5 minutes, then they hand the baby off, versus it is part of their responsibility to hold the child, and therefore that the child will bond to them if they still stay engaged, even if there's some frustration.
Great, thank you. I have one last question for you, and this is also related to attachment, but could you comment on the role that a father's history of trauma plays in their ability to attach with the infant, and also if it has a role in any postpartum symptoms that they might experience?
Yes, like trauma typically does worsen when you're having more stress and kind of this life change. So it's important for them to be, one, aware of it. That's why I always encourage people to think about early intervention to help with their mental health. That also applies to that bonding. If they feel like some of their trauma experiences limits their ability to engage with a child, like many times fathers have talked about, either abusive or just bad situations from their own childhood, that then plays into how they view parenting and how they might want to avoid certain situations. And you want them to be able to work with a psychologist or someone prior to the baby being born, so that when the baby comes, they can be the father they want to be based on their values, versus the trauma influencing their parenting behavior.
An important part. Great. Well, Dr. Fisher, thank you so much. It's just such a pleasure to have you, and such important work that you do, and we hope that you can take this field to the next level.
That's our goal.
Good luck on all your research projects, and have a good evening.
You too. Thank you.
Take good care.